these sessions. My name is Herbert Reitzamer. I'm from Salzburg. I'm a glaucoma specialist and chairman of the clinic here. And I have two companies here. One is Keith Martin. You know him, formerly based in the UK, in Cambridge. And he's not only a glaucoma wizard, he's also a wizard with the piano. And we've all heard him playing. And there is also a change during the last years in his life when he went to Down Under, and he's now stationed in Melbourne, chairman of the eye clinic there, and also the Eye Research Institute of Australia. He holds the Rigland Anderson Professor Chair, and we are very much looking forward to his presentation. The second speaker that I introduced to you is Anthony Kouach. He's from London, University College of London, and he's also a glaucoma specialist there, and he's also a surgeon at Moorfields Hospital, and he will tell us very interesting things today about 24/7 IOP control. So I'm very much looking forward to the presentations. And we start with Keith Martin with unmet need and challenges in the glaucoma. So please, Keith, enlighten us.
Well, thanks, Herbert, and thanks for the introduction. And it's a pleasure to join you from Melbourne this evening for this very interesting session. And thanks to Allergan for sponsoring. So these are my disclosures. So I was asked to think about some of the unmet needs and challenges in glaucoma, and of course there are many, and this is just really a small subset of the issues that we really have to solve if we're going to improve glaucoma care well into the future. I'm going to talk a little bit about how I think we need a better classification system for glaucoma so that we can target treatments to patients that are most likely to benefit from them. I think we need better ways to improve adherence to medical therapy. We need to understand better glaucoma pathogenesis, and particularly the role of cells other than retinal ganglion cells. I think we need better ways to measure intraocular pressure and to enhance risk prediction so that we can identify the patients most likely to go blind during their lifetime. And then I'll talk a little bit about neuroprotection, neuro enhancement, and optic nerve repair, as well as personalized glaucoma care. So this is just some bullet points really to get you thinking. I think we do need a better classification system for glaucoma. For some types of secondary glaucoma, exfoliation, pigment dispersion, we have a pretty clear idea of why the elevated intraocular pressure occurs. But for primary open-angle glaucoma, we often lump a whole bunch of probably quite different mechanisms together because they have a final common pathway that looks pretty similar with the cupping and the visual field loss. And yet, in some of these patients, it may be a predominantly vascular disease. In others, it may be more of a connective tissue disease. In still others, it may be more related to mitochondrial dysfunction, for example, in the optoneurin mutation patients. And I think in a lot of ways, lumping together all of these different types of glaucoma into something we call primary open-angle glaucoma has been unhelpful. And I think with genetic profiling coming along, we finally got the chance now, I think, to start to unpick that. And I think that will help us with targeting our therapies as well. Glaucoma is associated with some of the lowest adherence rates to treatment. And this is a comparison across a number of different medical conditions. If you look at the comparison even to statins for hypercholesterolemia or for bisphosphonates for osteoporosis, these are both asymptomatic diseases as well, but the adherence rates to treatment, even when glaucoma patients only have to take 1 drop a day, are even poorer than these other asymptomatic conditions. And so it doesn't matter how good our drugs are, if our patients aren't able to take them or aren't taking them, they're not going to get the beneficial effect. And I think that's part of the justification behind some of the work that's going on to develop slow release treatments and other new ways of dosing with glaucoma medications. We tend to think of glaucoma as a retinal ganglion cell disease, but I just want us to remember that glaucoma doesn't just involve loss of retinal ganglion cells. What happens to retinal ganglion cells is critically dependent on a whole bunch of other cell types within the eye and within the brain. For example, at the optic nerve head, retinal ganglion cells are really very dependent on astrocytes for their metabolism and for the resistance to mechanical deformation of the optic nerve head. And loss of that support, because astrocytes aren't functioning properly, compromises optic nerve function in glaucoma potentially. Microglial responses within the retina are very important in modulating the microenvironment of retinal ganglion cells, and yet we don't really think about targeting microglia with our treatments. Also, in terms of optic nerve repair, oligodendrocytes are critical in the optic nerve to facilitating repair after optic nerve injury. And again, we need to know more about that biology if we're really going to effectively repair the optic nerve. Another limitation we have is with the use of intraocular pressure measurement. It's still just done very infrequently. We get very infrequent snapshots, usually using 1950s technology. And although we've developed lots of different new ways of measuring things like corneal hysteresis as well as pressure, really these have not taken off in enough of a way to drive widespread uptake. And I think what we really need is new ways to measure intraocular pressure more dynamically and over longer periods of time. And there have been various attempts to do this by measuring features that correlate with intraocular pressure using contact lenses. But I think the most exciting technology is the intraocular pressure sensors that are coming in, and there are a range of these that are being developed. Some of them incorporated into intraocular lenses, some of them as standalone devices. But I think this will really give us the opportunity to understand what is actually happening inside the eyes of our patients. And I would love to have the ability to put a pressure-sensitive lens into glaucoma patients at the time of cataract surgery. Obviously, the real-world value of this remains to be determined. We need to think more about predicting risk, because we now have access to enormous amounts of information about our patients, and this was only going to grow. And Anthony Coadja has been very involved in work which is demonstrating to us that we can predict a large proportion of the risk of glaucoma from a single genetic profile for our patients. And I think learning how to use that information to target treatments more effectively is going to be a big thing that we're going to be doing more of in the future. We need to make our trials feasible. It's really disappointing how few trials we're actually doing in glaucoma for therapies other than intraocular pressure lowering. And I think we can do these trials. We need to make them shorter and we need to make them cheaper, but we can do these trials. We can be smarter about the way we use endpoints by clustering them, for example, at the beginning and the end of trials. We can recruit patients with less variability, a really simple thing that we can do to reduce the numbers we need in clinical trials. And of course, we can also consider recruiting patients who are already progressing. None of these things are beyond us, and we really need to actually put into clinical trials more of the sort of things that we're developing. And again, there's been quite a lot of work going on recently looking at what a clinically meaningful neuroprotective effect would be. Really nice paper by Gus de Moraes demonstrating that a 30% reduction in the rate of visual field progression is projected to have a significant effect on the health-related quality of life of our patients, because that's what we're trying to achieve. We're trying to achieve prolongation of quality of life. I have a big interest in the development of neuroprotective gene therapies for glaucoma, and this is a technology which has really hit its day. We have now the first licensed treatment for genetic disease is for Leber's congenital amaurosis, and we also have successful clinical trials at phase 3 for using gene therapy to target retinal ganglion cells for Leber's hereditary optic neuropathy. So these treatments are already coming. And the long trials do give us confidence that we can target retinal ganglion cells with a single intravitreal injection. And these therapies are also coming for diseases that don't involve single gene defects. And we're doing this for glaucoma and using brain-derived neurotrophic factor. There are a whole bunch of other different targets that you can target with gene therapy. So gene therapy is just a technology, and you can use it in many different ways. And I'm just going to finish off by just mentioning two other ways that we're currently using gene therapy. One is to stimulate regeneration of the optic nerve, and the other is to try to reprogram cells within the retina. So the central nervous system regenerates poorly after injury, and this means that recovery after optic nerve injury and spinal cord injury and brain injury is often incomplete. And by using gene therapy with a gene called protrudin, Vessi Petrova in the lab published this last year in Nature Communications. She was able to demonstrate that in a dish, if you sever these axons and treat them with gene therapy, you can get them to regrow. They don't normally regrow at all, and by treating with this gene therapy, you can turn these cells into fantastic regenerators like they are in development. And we've demonstrated we can do this in vivo and regrow axons up the optic nerve in vivo as well. Another way that we can use gene therapy is to reprogram glial cells, and we're really excited about this at the moment because we've discovered several ways that we can use CRISPR technology to reprogram Muller cells within the retina into photoreceptors, and this is work by Ray Wong in Melbourne. But we can also do this into retinal ganglion cells. So far, we can do this with human retinal ganglion cells in a dish, and we're looking at ways to do this in vivo as well. And finally, I think, in terms of unmet needs in glaucoma surgery, I'm not going to go into that too much because Herbert's going to be covering that in his talk. But I think we can really think more about individualizing surgical treatment based on aqueous outflow anatomy. And this is a technique that was developed in Cambridge and by Paul Meyer and taken on by Taz Katib and Jed Lusthaus, called hemoglobin video imaging, which allows us to image in real time at the slit lamp non-invasively the aqueous outflow pathways, and potentially gives us the opportunity to target trabecular bypass surgery to areas with good aqueous outflow. So I'll leave it there just with a summary of some of the challenges. There are many more, but these are just some of the things that I think we can think about when we look about what needs to be done to improve glaucoma care in the future. Thanks very much indeed.
Well, thanks, Keith. That was our first presentation. We'll have question and answers at the end of the session. And so we move right on to Anthony Kowach, who will tell us about medical management and limitations. Please, Anthony.
Okay, thanks very much for the introduction, Herbert. Can I just check you can see my slides okay? Okay, well, anyway. Hello everyone, it's a pleasure to speak to you today about the medical management of glaucoma and its limitations. These are my financial disclosures. So we know that medical therapy works, and our best proof that treatment works in glaucoma at all is for medical therapy. We know it can prevent the onset of glaucoma in people with ocular hypertension compared to no treatment, as demonstrated in the OATS trial, which lowered IOP by the use of available medical therapy at the time. Treatment reduced the risk of glaucoma progression compared to no treatment, again, in the early manifest glaucoma trial, which used laser trabeculoplasty plus topical bitaxolol to lower IOP. And more recently, latanoprost has been shown to reduce the risk of glaucoma progression compared to placebo in the UK glaucoma treatment study. And this, I think, remains our highest level of evidence that treatment works in glaucoma, with it being a placebo-controlled trial. I think we're all familiar with the major classes of glaucoma drops, including prostaglandin analogues, which lower IOP by increasing uveoscleral outflow, beta blockers, carbonic anhydrase inhibitors, and alpha agonists, which all predominantly work by reducing aqueous production. The more recently introduced rho kinase inhibitors, which increase conventional trabecular outflow, and the parasympathomimetics, which are also thought to increase trabecular outflow. The recently published 5th edition of the European Glaucoma Society Guidelines presents this flowchart for the medical management of glaucoma. It's advised to start with monotherapy if we're going to start with medical treatment. But of course, following publication of the landmark LIGHT study, we have now good evidence supporting SLT, selective laser trabeculoplasty, as an initial treatment. And this has resulted in SLT being suggested as an initial treatment option for open-angle glaucoma in both the EGS and AAO guidelines. Surgery is actually also suggested as a potential initial option in advanced glaucoma or selected cases in both guidelines. So now moving on, what are the limitations of medical management in glaucoma? Well, a definite limitation is that drops cause side effects. In fact, many of our glaucoma patients' only symptoms are from treatment side effects. We know that prostaglandin analogues can cause conjunctival injection, eyelash growth, periocular hyperpigmentation, cystoid macular edema. We know that beta blockers are actually well tolerated locally around the eye, but can cause significant systemic side effects such as bronchospasm, bradycardia, hypertension, reduced exercise tolerance, and impotence. Carbonic anhydrase inhibitors can sting a lot locally and cause an allergic dermatitis. They can worsen corneal edema or cause keratitis and can give a metallic taste to the user. We know the follicular conjunctivitis that alpha agonists can cause, and also dry mouth and nose, headache, fatigue, somnolence. Rho kinase inhibitors, I suppose we're still getting to know, but significant side effects include the conjunctival hyperemia and corneal verticillate. And parasympathomimetic agents can cause an increased myopia, decreased vision, or an eye or brow ache. And something all drops can contribute to is ocular surface disease, which occurs commonly, if not in the majority of glaucoma patients treated with glaucoma medication. While preservatives are particularly implicated, there are non-preservative related medication factors, and the higher the number of drops, the higher the prevalence of ocular surface disease, and also the worse the symptoms, patients report. There is also evidence that glaucoma medication can adversely impact future conjunctival drainage surgery success. Medications can have a toxic and immunoinflammatory effect on the conjunctiva, as demonstrated in 92% of eyes on multiple medications for over a year in this study. And David Broadway's work from the 90s is still often cited as evidence that trabeculectomy survival may be impacted by the previous use of certain topical medications. Adherence is another major problem. Drugs don't work unless you take them. And there's evidence that only 10% of glaucoma patients refill all their prescriptions for a full year. But adherence is complex and difficult to address as it has multifactorial causes, including social and economic, healthcare system related, individual drug related, and patient related factors. In each individual patient, there are usually multiple contributing factors. In this US survey-based study, the commonest factors included forgetfulness, difficulty putting in the drops, and the required schedule of drop installation. Evidence also suggests that adherence worsens with both the number of drop bottles that are prescribed as well as the number of daily doses. Therefore, combination therapy may be preferable where available. Another limitation of medical treatment is that we may be uncertain about its efficacy over 24 hours. I think it's likely that we underestimate IOP fluctuation, and we're now learning a lot from studies that use intraocular sensors like this one that is placed in the ciliary sulcus at the time of cataract surgery. This has shown considerable short-term fluctuations in IOP, even within a 3-month period, like in the data shown for this eye here. The IOP at, say, a point in time like noon can vary between 18 to over 30 millimeters of mercury. And this study showed even greater longer-term fluctuations. So it might be that IOP spikes only occur on isolated days. So the idea that we might know what's going on with a patient's pressure, even if we measure their IOP throughout a full day, is probably not a sound one, and we're probably missing IOP spikes at other times. Evidence suggests that trabeculectomy may be better than medical treatment at reducing these fluctuations. So while not strictly medical management, SLT is now a popular non-incisional treatment for open-angle glaucoma. Its popularity has been spurred by the remarkable finding from the LIGHT trial that 3/4 of participants receiving laser first were still controlled and drop-free at 3 years. Of course, that's in a trial setting with participants selected on many criteria. So how well does SLT work on all comers in our glaucoma clinics? We examined this across 5 centres in the UK, and we found that while the majority of patients initially respond, the majority had failed according to one of these criteria by 2 years. Another thing we found was that while the average response to SLT is good, there's great variation in individual response. Being better able to predict who will do well with SLT is definitely a research priority. So, given all these limitations, should we be considering surgery as an initial treatment rather than medical treatment? Well, the last Cochrane review addressing this question suggested that further RCTs are needed, especially in people with severe glaucoma. And that's what prompted the excellent TAGS, Treatment of Advanced Glaucoma study, which has recently been reported in the high-impact British Medical Journal. TAGS was a pragmatic RCT randomizing around 450 open-angle glaucoma patients presenting with advanced disease to either early trabeculectomy or escalating medical treatment. There was no significant difference in the primary outcomes, which measured quality of life. But there was a big difference in the secondary outcome of IOP, with trabeculectomy achieving around 3 millimeters of mercury lower. There was a small but statistically significant worse visual acuity outcome in the trabeculectomy group, and a health economics evaluation found medications to be cheaper than trabeculectomy at 2 years, but modelling over a lifetime found trabeculectomy to be cheaper. So, initial trabeculectomy seems like a reasonable treatment option for advanced open-angle glaucoma, but perhaps we're not willing to take the risks of surgery for patients without advanced disease. What are future directions for medical therapy? Clearly, improving adherence with modern technologies will be of benefit, and there are emerging new drug delivery methods which may increase adherence and reduce ocular surface disease. There's also growing evidence that genomics will enable us to predict which patients will respond well or otherwise to individual treatments. And maybe if we can develop a highly safe and effective surgical treatment, we may not need so much medical treatment in the future. Thank you for your attention.
Thanks, Anthony. Very interesting. I'm sure there will be lots of questions at the end. They're already coming in. I will now proceed with my presentation on MIGS and where are we now. Let me start this. Okay, here we go. So these are my disclosures. And as we've heard before from Anthony, there is an issue with sending people to surgery primarily. And there has been a study done by authors Gabor Holo and Tony Homer, where they looked at the referral practice of physicians, and they found out that in Europe, there is little less than 40% of patients that are referred at the right time and appropriately to surgery for glaucoma. But there is more than 50% that are not timely referred. So this might have something to do with the invasivity or the side effects of surgery, and there has been always a struggle to develop a different way to do glaucoma surgery, and MIGS is one development on that way. And so you see the definition of MIGS by EGS is that it's only an ab-internal non-blood-forming procedure, and that MIGS may be suitable for patients with mild to moderate glaucoma. So this is an arbitrary opinion of EGS and can certainly be defined differently individually by yourself. So how is intraocular pressure developing. We know the Goldman equation. We have aqueous flow. Aqueous flow comes out of the ciliary body here, flows through the pupil, and then emerges through different resistance pathways, primarily the trabecular meshwork and uveoscleral pathway. And there is also episcleral venous pressure that plays an important additional role in defining intraocular pressure. So, of course, there has been lots of research going on, and we've defined a new model for IOP, considering all the factors that influence IOP. And Anthony and I had a discussion on how to figure out if there is any prediction of IOP dependence on water drinking or daytime. It's been somewhere in these many variables that we see here. And Jeff Keel has done a fair amount of modeling on that. Also, new approaches like the suprachoroidal space with low pressures for filtration of aqueous has been explored and has been utilized by glaucoma implants. So what we see here is how aqueous is produced in the ciliary body, flows through the trabecular meshwork and goes out through the classical and the alternative pathway via trabecular meshwork and Schlemm's canal and episcleral venous pressures, and the suprachoroidal space through the iris root. There you have the various sites of resistance that need to be overcome by aqueous flow, and also from that follows that there are certain ways where you can put in implants to facilitate that flow. So there is the chamber angle where you can pierce through Schlemm's canal. There is also the suprachoroidal space that you can utilize with implants. There is the cornea, that's a very new way to do it, where you can connect the anterior chamber with the open space. And there is the way where you can drain aqueous through implants to the subconjunctiva and form a bleb. All these new techniques that are available rely on the basic principle that there is only 2.5 microliters of aqueous produced per minute. And only if you give no eye drops that reduce that production. So when you put in an implant, there is the flow through the implant that always stays the same. So the full amount of 2.5 microliters is the maximum available. So when you increase the diameter, for instance, it's still the same amount of fluid that goes through the implant, but it means that it takes a lower pressure to push it through. So the pressure that you actually get at the outside of the implant depends on where this implant is placed into. So it could be a bleb, it could be Schlemm's canal or others, and also suprachoroidal space. So you have these pressures that you're up against, and we need to look at how you can maybe modulate these pressures. So there is the resistance of the implant, and there is the resistance of the bleb, for instance. And we know that for some implants, we can deal with these two variables. But we always need to consider that when you have the flow through the implant, you still have flow through the residual pathways that are still in place, which is trabecular meshwork and suprachoroidal space, for instance. The implant resistance is important, episcleral venous pressure is important, and the position of the implant, as we said, but there is also bleb resistance that we can change and we can handle in different ways. Never forget that there is also a certain amount that goes through the other pathways, as I mentioned before, and that there might be also cortisol responders. So after surgery, when you do your post-op management of the patients and give them lots of cortisol drops, always think that the rest that goes through these pathways, especially the trabecular meshwork, might depend on cortisol. So if pressure on the long term doesn't go down with cortisol treatment, think of tapering that. Here you have the anatomy of the chamber angle. So you see here the scleral spur and the trabecular meshwork. You see the iris root, and you see the conjunctiva out here. So those are basically the sites where we can put in MIGS nowadays. Here are some examples for trabecular meshwork bypass systems. You've all seen that before. There's small ones, and there's larger ones that cover a larger area, which makes it more likely that you also hit the collector channels opening when you put that in. There is also there are surgical possibilities to remove the trabecular meshwork and thereby reduce the resistance. There is also the possibility to put in suprachoroidal implants, as shown here. We currently have none of these implants in our routine use. There has been an implant that was retracted from the market recently, and others didn't continue, but we'll see. It's a very appealing place to drain aqueous into, and various materials are under development currently to increase the facilities of these implants. And there is another one for the subconjunctival implants. There is from inside or from outside implantations possible, and those depend on the function of a bleb. There is also new technologies that we have available in our microscopes in surgical suites. So we are not always dependent on gonioscopes, for instance. We can use OCT technology to place implants very accurately in a way that we have more safety and can be sure that drainage will be well on the next day of surgery. There is another one that drains aqueous to the atmosphere. It's implanted here at the rim close to the limbus. That's a fairly new way of draining aqueous, and it's also not commercially available now. It's still in studies. So let's go back to the definition of the mixed procedures. So first, it's not bleb forming. It's been called mixed plus in the past for the bleb forming procedures, and EGS says that mix are suitable for patients, or may be suitable for patients with mild to moderate glaucoma. So I'm not a real great fan of mild to moderate or severe glaucoma, because we have individuals in front of us and they need individual target pressures, and it depends on various factors. We see that different mixed procedures have different risk profiles and different efficacy in terms of how well they can lower IOP. And so if you have mild, moderate, and advanced glaucoma, which one would you use for which? Or actually we have 4 in place, so maybe one for no glaucoma, but that's just a joke, of course. But we have no handling of which procedure to use. But there is a good concept of EGS, which is target pressure. And the way I use implants is that I define target pressure, and then I look at the potential of the various MIGs that are available and whether MIGs make sense anyway. And it depends on of course, whether there is severe or moderate glaucoma or mild glaucoma, but it also depends on the rate of progression, the life expectancy, the untreated IOP, and there are many other risk factors that need to be taken into consideration. So which patient to choose for which mixed procedure depends on the target pressure. What is the goal? Does this patient have tolerance to eye drops? Because we know some MIGs only develop their full efficacy if you add eye drops and reduce aqueous flow, for instance, or increase the still in place other outflow pathways. There are anatomical considerations. For instance, if you have high myopia, a person with high myopia, they have very thin scleras, and sometimes a mixed procedure might be easier than doing a trabeculectomy in those. On the other hand, people with hyperopia may have a very narrow chamber angle and might not be possible to subject them to a mixed procedure. Also, the question is it necessary to do a cataract surgery, because you might be able to combine the procedures? And what is the expected compliance and adherence of the patients? Because MIGS do tend to be different in maintenance. The bleb procedure are more high maintenance, and the angle-based procedures are as they are, so there is no change post-operatively possible anyway. You can train mixed procedures. These are the groups that come regularly to Salzburg to be trained there, and you're very welcome to join us here. And we have different temperatures here also, and since it's very hot now, I show you a nice image of Salzburg in winter time, where we have can be quite cold here, but very nice. So thank you for your attention, and we now go back to our discussion. So please, Keith and Anthony, join in. And we now go to the question and answer session, and so there is a question for Keith, I guess, where the question is, which group of glaucoma medication proved to have neuroprotection effects?
Well, that's an interesting question, and the answer is that very few have actually been studied in humans in this way. So we've got sort of indications from animal models for various classes of glaucoma medication, but this has really been quite poorly studied in humans. The low tension glaucoma study was one which attempted to look at the effect of brimonidine versus timolol on visual field progression over time. And it seemed to show a slower rate of progression in the brimonidine group compared to the timolol group. There are various issues with the study in terms of a higher dropout rate due to side effects in the alpha-GAN group, and quite a fast rate of progression in the beta-blocker group, faster than the rate of progression in some other studies, in control groups. So there's still a bit of unpicking, I think, to do there. But really, you would think that we would have tested the effect in terms of protecting the optic nerve of the medications that we use to lower pressure, but we haven't a lot of the time. We haven't put them up against each other. We assume that the same amount of pressure reduction will give you equivalent amounts of nerve protection. A lot of the time, there's no evidence for that at all, and we really need to be thinking about looking at functional outcome measures from our glaucoma treatments, because really our patients don't care about pressure, they care about maintaining and keeping their vision, and yet that's not what we're testing in our studies.
Absolutely. Let's go to the next question, which is about tags. So Anthony, you told us about the tag study, which might suggest that we could do trabeculectomy earlier than we used to do in the past. So how did that influence your practice with your glaucoma patients?
Well, it's only just been published, but I think, I think some of us, when we're presented with a patient, we think surgery might be a reasonable option. Now having a big study which has specifically addressed this question supporting us, I think can give us more confidence in doing surgery earlier, and may also even give the patient more confidence. So I think really maybe the results weren't surprising. Maybe some of us might have thought trabeculectomy would be better because you need to get that low target pressure quickly, but they seem roughly equivalent on many levels. Although if you're getting 3 millimeters of mercury lower, maybe over a longer than 2-year follow-up, maybe trabeculectomy would win out. Certainly the modeling suggests that trabeculectomy would be cheaper. So I think following this, I think I'm going to be more inclined to offer and maybe advise trabeculectomy in advanced open-angle glaucoma patients. But as you nicely said, everyone's an individual, and the patients with advanced glaucoma are all quite different and have different will have different attitudes towards treatment, and things like the fellow eye, the status of the fellow eye is very important. So it always ends up on a case-by-case basis.
Anthony, I think the study reminds us that early surgery is an option, and sometimes having too much choice is a problem. We've got so many different medications and combinations and what sometimes happens is that people kick the can down the road. You know, patient comes to the clinic and the medication gets switched, and multiple classes are tried, and sometimes we don't address the fundamental problem, which is the patient just can't take drops, or you know, just doesn't manage to put them in effectively, and you know, the real world effect of surgery can sometimes be bigger than the effect that we see in clinical trials, where we're dealing with adherent patients and people who are motivated. And so again, it's good that these sort of pragmatic design trials are coming through now, because they do reflect sometimes better what's happening in the real world compared to, you know, the very rigorously regimented trials that we have done in the past.
Yeah, very true. I think in general, we need to push for earlier referral to surgeries. That's the practice that I see in Europe, that people are usually waiting too long to send their patients to the clinics and to the glaucoma specialists to do the surgery. But on the other hand, we've also seen in the LIGHT trial, and Anthony, you've mentioned that very nicely, that the study situation could be very different from an intention to treat population. And that's what I thought myself when I read that publication. I thought, well, mine are not doing as well. I have roughly 60% responders, and the rest, it just doesn't work. So I was very interested in your opinions, and obviously the audience is also on how well the SLT in your practice works.
So yeah, in my practice, when we've audited it, it probably is more aligned to those real world outcomes. What we've got to remember, I guess, with LIGHT is the SLT worked particularly well in people with ocular hypertension, and you were allowed to revise the treatment target. So maybe that's part of it. The other thing is treatment naive patients. In our real world data and in our audit, we've got a mixture of treatment naive patients and those who've received previous treatment. Although interestingly, we didn't find a difference. It seemed to be whether you were on drops or not on drops, SLT worked equally well. The biggest driver of whether SLT works or not is how high the intraocular pressure is. So if you're starting off with an already fairly, you know, an IOP less than 21, you might not expect such an effect as if you're starting off with a pressure of 26. And so it could be that the population that was recruited to LIGHT had higher pressures, and I think they did when we compared this. So the future really is identifying, being able to predict who's going to be a really good candidate for SLT, and rather than it being working in 60%, you know, maybe if we can look at genetic markers or just look at clinical factors that can predict response, we can get that up to 80–90% in the future.
Exactly. So we need to identify the patients that are high potential for great efficacy, and others we just don't use it.
Yeah, Keith alluded to that a little bit earlier with the genetics, and you know, all the genetic discoveries we've found for IOP regulation. The #1 biological pathway acts only on Schlemm's canal and collector channels, and not trabecular meshwork. So if we can somehow, through genetic markers, work out which of POAG patients have got a non-TM problem, maybe that will help us not do SLT on people who won't do well with it.
Exactly. So guys, it was such a pleasure to be in this session with you. Unfortunately, time is already over. We ran out of time so quickly. I want to thank Allergan again for hosting us, and WGS. I think it was a great session. It was very informative, and maybe it has changed your daily practice a little bit with your patients, and you look at them in a slightly different way now. If we have achieved that, we are very happy, and we are very much looking forward to seeing you